Hi, everybody. Welcome to today's Research America Alliance member webinar. Thanks to everyone in the audience for joining us today, and always for your ongoing partnership. Today, we have the opportunity to talk with Dr. Rena D'Souza, Director of the National Institute of Dental and Craniofacial Research. She's going to speak with us about the increasing evidence linking poor oral health with diseases such as diabetes, cancer, and cardiovascular disease. It seems the more we learn about oral health, the more it's connected to overall physical health. So as usual, please type your questions into the Q&A box or the chat as we go along, and we will do our best to ask them when we get to the Q&A portion of today's meeting. And with that, let me turn it to you, Dr. D'Souza. Welcome.
Thank you. Great. I'm very happy to be here and to be able to address this audience who I can't see, but I know you exist, and just be able to share with you some of the dreams that NIDCR holds right now in this world, these unimaginable times, how we organized, how we're thinking about the future, how COVID itself has taught us the lessons for the future. So I will, in the next 10 to 15 minutes, hopefully cover those topics and then open to answering any questions and also viewing this as the beginning of a conversation. Research America is absolutely vital for all that we do in all the institutes at NIH, and the National Institutes for Dental and Craniofacial Research is no exception. So if you looked at the times we live in, it's hard to not consider this quote by Charles Dickens in A Tale for Two Cities. And I want to emphasize that the hopeful side of all of this, that despite the tragedy of the losses that COVID has brought, that we've learned so much, that it is in fact the age of wisdom and the age of belief, and where the spring of hope can get rid of the despair, and we actually look at a season of light. So that's how I approach the days to come. Just a little background about myself. I am a clinician scientist, a dentist PhD, who for academic lifetime has pursued curiosity-driven research with the real passion for giving back to training the next generation of clinicians and researchers for the future. So because everything is exploding in terms of science and technology, that is an important part for me to want to give back to the field and to individuals. The commitment to diversify and to have enforce equity and inclusion in all we do, along with the development of human potential. These are things that are very much at the core of who I am. And I bring that sense of calling and the drive to make a difference to the job. If you looked here, this is a beautiful collage of my beautiful staff, but more than anything else, other than the fact that they've been amazing support in this transition period for me, which has been entirely virtual, that if you looked at each one of them, you'd know that there is a human soul behind each of those faces. So our faces, this entire structure, gives us that sense of self-identity and worth, self-worth, right? It gives us that sense of well-being and identity. And that is the human face. That is what NIDCR cares about very deeply, and everything around it. So we have in the structure, we call the dental, oral, and craniofacial complex, very unique systems that are not present really in, or at least if they are present, serve as great models for understanding how we are parent, how we form hard tissues, how we taste and experience other senses, how we chew on our food. All of that is exemplified in this as a complex that we study. We also have the oral cavity as a portal of entry. If you think of the common risk factors for cardiovascular disease and for diabetes, it's bad diets, it's tobacco, e-cigarettes, opioid misuse, nutrition, all of that needs the oral cavity to enter the system, or is directly at the forefront of the insults that we place on our body. We also have the oral system as a manifestation of systemic diseases, very often being the first indication that something is wrong in the rest of the body. That it is, in fact, gives us the opportunity to look at health in an individual, not by disease alone or by one specific tissue, but by a combination of health determinants that make us who we are and predispose us to diseases and allows us actually to not completely get rid of something if we don't change or modify our behavior and our social circumstance. We can also look at the oral cavities being a way in which we can monitor the progress of systemic diseases or patient compliance to a given treatment, post-treatment procedure. In the end, it is a critical determinant of identity and self-worth. But look at what we have in front of us today. We own practically the most common of all diseases, the infectious diseases in general, and the non-infectious diseases that like trauma and cancer, though some cancers are infectious. And that entire burden is about 500 billion worldwide. So we carry that heavy burden. Cleft lips and palate being one of the most common of all genetic disorders, untreated dental decay, the most prevalent of childhood diseases, periodontitis or gum disease affecting at least 47% of our population. And now rising to the very top, HPV-related oropharyngeal cancers becoming more dominant than cervical cancers of HIV origin. And then we have these very devastating conditions worldwide. In Africa, a condition called NOMA, that is really a polymicrobial caused by many bacteria, attacks the face of children in Africa and is absolutely devastating. It literally eats up the entire facial structure. And we know very little about that disease. And in general, complete tooth loss affects a significant number of our population, a lot of whom, as you know, are aging and living longer. And so we look at the loss of teeth as being associated with cognitive decline and even associated with Alzheimer's. We were created in 1948 for a very specific purpose. It was the time of the war, post-war, and wartime veterans, or those being deployed, had such bad oral health that it was noted that we needed a national institute to look at oral health issues. And that's how the National Institute of Dental Research was created in 1948 as the third institute of NIH to be created here in Bethesda. We changed our name to NIDCR to indicate that dental and craniofacial actually go together. And we stay true to that mission today, which is to take care and ensure that oral health is afforded and available to all our citizens and as well globally. So we have a budget that is dispensed mostly for extramural research. So we fund institutions and programs across the country, 80% of that. And we're privileged to have our own researchers on campus that also run clinical trials and are focused in 5 distinct areas. We have 27 investigators, and they are very open to sponsoring, visiting fellows, interns, postdoc fellows as well. And we stay connected. The intramural and extramural world stays very connected. Now, what do we actually research? We research all of these areas, and they cover diseases, they cover disciplines, they cover scientific focus areas. And the one on the far right, you can see kind of in the middle, is the area of data science that is emerging as a very important science for which we do need experts right now in the field. This is the areas of our intramural program that cover really the breadth of what we deal with in oral health. And they range from very basic science type driven investigations to clinical. We're building up our clinical investigator pool at the intramural program. Matt Hoffman is the director, and Lillian Shum in the previous slide is really the amazing leader for our extramural program. Now, during COVID, it was very important for us very quickly to mobilize and to be nimble and to come up with funding that would make available new technologies for us to test conditions in dental operatories to very, very basic studies, as you can see here. We also had our own investigator, Blake Warner, who is an intramural investigator, understand and research and make known the importance of saliva in the transmission of the virus, of the SARS-CoV-2 virus, that in fact it proliferates in saliva and actually once in the salivary gland can divide quite prolifically. This gave rise to the belief that in addition to the nasal lung axis, that the oral gut axis was playing a role in COVID transmission. Peter Babello's also forwarded some wonderful technologies on new testing materials. So as we take a deep breath, we realize, so beautifully illustrated in this cover of Time magazine, that we will never be the same, that we have appreciated more than ever the importance of human connections, being able to not be stuck in a rut kind of thing, but more nimble and pivoting, flexible, relying on partnerships, innovation, high-risk approaches, relying and building infrastructure and capacity needs as we saw them emerge in the pandemic, realizing the health inequities and social determinants of health inequities, really disparities actually exist to a point where they are detrimental to our quality of life and our well-being, that telehealth and access to care, in fact, can work very well for those who have difficulty, especially in rural areas and remote areas, in accessing care of all kinds. That science and technology matter, as shown by the president's new appointment of Eric Lander to his cabinet, the first of its kind, and that leadership in any of these situations really makes a difference. So I want to thank you there for bringing all of this to fore. Am I running out of time? No, Jenny.
No,
okay.
no,
So
no.
we've also kind of focused on a strategic plan that doesn't take one area of research and focuses, but looks at the need for us to make it user-friendly, patient-oriented, diversifying and making sure that our workforce represents the demographics of the nation we serve, because we are a federal research funded organization, and always being able to look at what we do and whether we're doing it well and measuring the results and the impact of what we do. So we have a new plan, which I'm just going to illustrate here, that keeps the patient at the very center and that relies on all kinds of research to get to looking at the patient as a whole. So it's not just basic alone, very important, but clinical research, trials research, implementation sciences. How do we take what we create at the bench or at the chair side and translate that into policies that make a difference to the lives of individuals and their communities? And the goals we have are to connect and to find the meat, put the meat on the bones of making oral and systemic health inextricably linked, to be able to garner in goal 2 individualized approaches that are more precision based, to look at each unique individual and come up with the right treatment at the right time for the right reason, to be able to take in goal 3, what I said was implementation sciences to the community and to policies and advocacy, to be able to look at the next future, a generation of scientists, make sure they're diverse and well prepared to meet the unprecedented opportunities for science and technology advances, and then finally being able to leverage our stakeholders to look at our partnerships with a new set of lenses so that we can really make it a team effort, which is what we need to move to make oral health and health available for all. We have a new report that was initially commissioned by the previous Surgeon General that NIDCR assumed responsibility for. And we are very proud of the report. We want it to be a living document that is not sitting on a shelf, but actually has a list of calls for action items. And I will be in touch with Research America to help us disseminate the information there. It's very data driven. It's not fiction, it's actually facts. And we have a vision for how best to make that report effective for improving health for all. We realize that in dentistry and where we draw our chief pipeline for scholars, and us and all of NIH need to diversify. And for that, we've created a new multi-pronged approach of engaging private-public partners in looking at the issues that we struggle with, and including high tuition, loan debts, difficulties in attracting first-generation college goers into the profession, and then reaching out to develop a very strong cadre of biomedical researchers for our field. We really do need to diversify. We have our large practice-based research network, which is really an incredible resource for the Institute and for our community, where we engage our private practicing dentists in chairside research that is addressing the questions that are routine or day-to-day questions that oral health practitioners encounter. We've also very recently re-engineered our public health training program so that we add 2 years of a postdoctoral research experience that can leverage the resources from other institutes on campus, because we have an unparalleled set of opportunities to train public health researchers for dentistry and for oral health. Now, if you looked, I showed you some of these numbers in the previous slide, but this is a global problem that has drawn the attention of worldwide community. And what's really critical, it's been a historical landmark resolution, is the WHO's passage or recognition that oral health is integral and critical for general health. And general health is reflected in oral health. So it's a two-way thing. And his plea was that all member states take that seriously and actually incorporate into health policies a universal health coverage package that would include oral health. And that we can see is actually on the table for consideration right now in a new Medicare bill. So the stars are aligned for so many reasons. And I think COVID has helped align them for us. And I've described all of these opportunities, and we look at it as a tipping point for oral health as well. So even though I will not volunteer to go up in space, even if it's a discounted trip, I'm not going to do that. But I sometimes look up at the stars, and I can look up and look at them being aligned and feel I can dream. I can dream of a world where every child can lead a life that is free of stigma and poverty. And I think you all share that with me, that we can imagine a world where all the factors that seem to influence our being, our well-being, are really all considered as we aim for health for all. That we look at the risk factors that are common to all diseases, or at least the major ones, and try our best to mitigate them or eliminate them. If that would be great if we could eliminate them. And then finally, a world where an aging population living with healthy minds, bodies, and uplifted spirits can light up the world with a full smile. And I say that because of the connection between cognitive decline and the loss of teeth that we see in our elderly. And we have very, very discrete strategies and technologies to aim for the very stars, the very best, such that if we are successful with preventive approaches, we don't really need the cures and therapies, but things take a while. This takes a while to develop, and it might be decades before we can actually have the right balance between prevention and curative approaches. So with that in mind, I want to thank you for listening, and to assure you that, and to join you in partnership to create the future that is promising for us all, and that we count on your support to really move health for all through your support of oral health. So I want to thank you for listening, and leave you with this quote from my favorite scientist, Marie Curie, who said that, we feared so much, we understood so little, but now as we understand more, we can fear less. And I think that stands so true today with COVID itself. And also about, when we look at all the complex diseases, we can fear less because we know so much more through science and technology. So here I am thanking the same beautiful faces, the staff that make every day a privilege and an honor to be with NIDCR. Thank you. Thank you,
Dr. D'Souza.
Yeah.
Thank you so much. Wow, what a wonderful presentation. The way you situated oral health and what's happening in terms of COVID and the broader science and technology arena and kind of the human condition.
Yes.
So it was both informative and highly inspiring. Thank you. I'm going to kick off the first question. I have a sense, just from talking to a few people I know who might even live in my household, that dental visits are among the visits that medical visits that people have put off during COVID.
Yes.
Have we seen the impact of that in terms of disease?
Yes, that's a very, very thoughtful question. And I can say the broadest strokes would be, if you're looking at disease prevalence in our society, the use or misuse of opioids has almost tripled during COVID. And opioid-related suicides and deaths have really increased. Now, there is a connection between opioids and dentistry, but that is not the theme. So initially, there was most dental operatories had shut down, because of the fact that they were seen as being risk environments, high risk environments, where aerosols generated with drills, water sprays were seen to be not, and ventilation all seem to be not in favor of mitigating viral spread. But the ADA did do a study where they tested all these systems. And in fact, NIDCR sponsored a study where it was shown that that was not the case. And then you saw a surge back of offices opening up and individuals going in at least for preventive treatment. But what's worthy of noting is that the same group of individuals that succumbed, that were in the groups or the populations that don't access care, don't have the resources, who succumb to COVID, are the same groups that actually show the highest level of oral health disparities and inequities. So that parallel still exists. Individuals are going back to seeing the dentist, mostly for preventive work, but also for surgical work. So it's coming back quite well now to almost, I think it's almost 80% of practice volumes are back.
Very good. Thank you. Thank you. I'm going to turn it to my colleague, Anna Platt, for the next question.
Thank you, Jenny. And just as a reminder to folks, please feel free to put your questions in the chat or the Q&A box, and we'll do our best to ask them. So Dr. D'Souza, one question that has come in, there's a focus on developing good oral health and oral health habits early in life. And has research been done on what works for improving adult oral health habits? And as a follow-up to that, do dental care behaviors need to be modified as a person gets older?
Yes. Oh, what a great question. And I'll tell you a story. I haven't made it up. It's actually a real story. So a combination of approaches that involve dentists reaching out to pediatric physicians led to the encouragement of visits to the dentist between 1 year and 3 years of age, making it mandatory almost for every child, because every child must see a pediatrician at some point, and that referral was made to a dentist. And either the pediatrician physician or the dentist placed sealants on this child's fluoride delivering varnishes on these newly erupted baby teeth or primary teeth. That led to that combination of 50% reduction in early childhood caries. Now, guess what? This is the the sad part of the story. As you get looking at older age groups, you see suddenly that that reduction no longer exists. That caries becomes the most common disease of childhood, the most common reason why children miss school, the most common reason why you would visit an emergency room or ER. Why? Because we didn't do exactly what you said. There wasn't, I'm not being critical of the profession, but the need to behaviorally modify throughout the life, to condition, to reinforce, to engage the community has to be an ongoing process, because our behaviors change as we morph from one age to the next, as you know. And adolescents actually need a lot of care. We are finding out, yeah. So that is absolutely true. Behavioral social conditioning, looking at the environment, the socioeconomic determinants, the patient at a whole, the entire patient and who you're exposed to, your family and your community is all important to maintain health through life.
Mm-hmm.
Yeah.
Mm-hmm. Got it. Thank you for that. So another question that has come in, excuse me, with all of emerging research showing the associations between oral diseases and other diseases, how does NIDCR work with NCI, NIDDK, NIAID, NHLBI, and other institutes?
Wow, the third brilliant question. I love it. Very importantly, for practical reasons, our budget is sizable, but it doesn't compare to NCI or to the bigger institutes, right? So we have, not for that reason alone, but because we share common interests. So we have to look at oropharyngeal cancers, difficult to diagnose early because it's not easy to see them. Early dysplasia requires that we collaborate with NCI. They've developed a new home care kit to diagnose, that patients can use on themselves to diagnose cervical cancer if you're at risk, HPV-induced cervical. So why can't we use it for oropharyngeal lesions? So that is a collaboration that's ongoing. We're doing a lot of, practically with every institute, we have joint grant mechanisms. Investigators are funded by sometimes more than one institute, and we're coming up with combined grant announcements so that we go beyond our dental field and attract individuals from other expert areas. So it's happening in multi-pronged ways. Yeah, and we have to do that.
Dr. D'Souza, we have a question regarding the current debate about including dental care in Medicare. And I wanted to pose that, but a broader question, which is that as the links between various aspects of human health and oral health become stronger and stronger and more evident, are we seeing a change in insurance coverage, both private and, in this case, public, of dental care?
Yes. You know, it struck me that Medicare, that everything above the neck, vision, hearing, and oral health are not included in Medicare coverage, or haven't been so far. Now they are on that bill waiting for approval. So my feeling is, on one end, if we have the scientific evidence to say that it's one body and we shouldn't be separating our body parts, right? Then we should act like that on all platforms of integration. I'm just thinking very broadly that would then invite us to think that we need to have oral health as part of our universal coverage or our national coverage, that we ought to be not separating out and having a different set of fees and services and for oral health that is set apart from the rest of medicine. So I think that integration, that opportunity to integrate our health records, our care, provider provisions exists right now. It's an opportunity that I hope we don't miss out on.
Thank you. Anna, I've got another one, but okay. Please,
no, go for it.
You get to go next.
Oh, okay. Yeah, I know we're right up at time. But so one question, Dr. D'Souza, is can you talk about how oral health can be used as a screener for certain diseases?
Yeah, hugely. I mean, you can, unfortunately, if you look at a young individual that's addicted to methamphetamine, meth, you can see a meth mouth from a distance. Every tooth has cavities right around because saliva is affected. And when you don't have enough saliva, you're prone to dental decay. So when in radiation treatments for cancer, if you knock out the salivary glands, you're going to get a lot of decay. So this is in a different scenario where the drug itself and the drugs itself actually control or decrease saliva. So starting from there to developmental disorders to there's so much that is systemic, can be revealed in the mouth. Now, there is a strong association between diabetes and periodontal disease. And it makes sense because insulin is present everywhere. And the tissues around your tooth rely on healthy levels of insulin. And you get too much, if you don't have enough, then you're not going to heal correctly, and you're not going to ward off bacterial invasion, which is what happens in gum disease. So an example that you all would all be familiar with, Kaposi's sarcoma, was one of the first indications of HIV positive AIDS patients. It's really what helped identify them and know that they had succumbed to HIV. You can be HIV positive, but not AIDS right? So you may not have the clinical manifestation of AIDS infection. So yeah, so many vitamin deficiencies, many things that go on, and you can see even from COVID, the loss of taste, the dry mouth syndrome, all kinds of things were manifested in the oral cavity. Very important portal to the rest of the body.
Absolutely.
I know we're just past our time, but do you have a moment for one more question?
Sure. Yeah, yes, absolutely.
This is an issue I've worked on over the years. Well, we're all so focused on vaccination around COVID, and another newer vaccine is the one for HPV.
Yeah.
You mentioned an increase in oral cancers, and I just wonder, have we seen a slowdown of uptake of the HPV vaccine? Do we need to do better education and outreach to increase the numbers of young women and men who are being vaccinated?
Yes. Very good question, and it's very timely and significant. We started off wanting the vaccines, and we were targeting young girls, right? It turns out that young boys were just as prone and susceptible. In fact, today, men are 3.5 times more susceptible or they're more affected by HPV than women are. And so that we have now a gender bias more leaning towards males is something we found out. I think the vaccines are working, and we're hoping that they work even better, but they are more preventive. What we really need is to be able to, if someone didn't get the vaccine in time, or the viral load dominates, as would be in COVID, where you supersede the immune protection you get from the vaccine and you come down with the lesion, can we diagnose that early? That is the challenge for the field, so that we don't allow this devastating condition to progress. But I'm thinking that the vaccinations in the end will really come to being very beneficial for HPV, these oropharyngeal cancers. Yeah.
Dr. D'Souza, I think we've all learned so much. Thank you so much for your time.
Thank you. I just loved it.
You'll leave your slides with us, and we'll post
Absolutely.
those
Sure.
as well as this video. Thank you. And we certainly look forward to working with you in the future.
Absolutely. And please invite me back. I want to keep the conversation going, especially in the year to come, as we try to get the word out about oral health and its status in America. So thank you for inviting me.
We will certainly do that. Just 2 quick announcements, links for which are being added to the chat. On Thursday, we'll be meeting with Paul Epner, who is the CEO and the co-founder of the Society to Improve Diagnosis in Medicine. They work on equipping physicians with the right information and diagnostic tools. And also a plug for our Civic Engagement Microgrant program. We're now in our 4th year. Applications are due by April 12th. So if you know any, and Dr. D'Souza, I'm so glad you stayed on to hear this. This is a program for early career researchers, postdocs, grad school level, med school, MPH, who might be interested in projects that are centered on science communication, public policy, and building partnerships with public officials and the community. Most of the groups we fund are on campus, but we also have funded groups through scientific societies. We have an information session tomorrow, and please reach out if you'd like more information, and we hope you will spread the word.
Yes. Yes.
So great. We'll get you some information directly, Dr. D'Souza. So to all of those who have joined us, have a great rest of the day, and we look forward to seeing you on Thursday. Thank you.
Thank you.